The title of this whole session is Adolescent Surgery. They look like adults, but they aren't the same. But I have to say, for this topic, they pretty much are the same. So let's get on. So I have nothing to disclose. So I'm going to start off with a case presentation. This is the story of a 13-year-old boy who was referred to National Jewish Hospital in Denver, Colorado from Kansas. He came in with a lifelong history of recurring episodes of barking cough that would occur about 3 to 4 times a year. They would usually start with a 24-hour history of a prodrome that would consist of fatigue, sore throat, a slight cough, but would then develop into a full-blown barking cough spasms that would last about 1 to 3 weeks. He would also complain of a chest tightness when running. His past medical and surgical history of interest: he had no eczema, he did suffer from some rhinitis, he'd undergone an adenoidectomy and PE tube placement at the age of 2, and some sinus surgery at the age of 5. His medication history over the past year consisted of multiple doses of steroids. In January, he was on a 4-week course of pretty high-dose steroids. In April, he was on another 3 weeks of prednisone, August, 5 days, in September, 10 days. He had also been on immunotherapy for the past year, and he was taking Singulair, a leukotriene antagonist, every day, and Symbicort, an inhaled corticosteroid, long-acting beta agonist combination, twice a day. On examination, the effects of the steroids were obvious. He was Cushingoid and obese. He had a hoarse voice, clear nasal discharge. His respiratory effort was normal, and he had good air entry, clear to auscultation. He had stria on his abdomen, but otherwise everything was normal, and there was no evidence of any clubbing. Investigations prior to presenting to National Jewish included skin testing in 2007, which was positive to multiple aero allergens and prompted them to start him on immunotherapy. His serum immunoglobulins were normal. A CT of the sinuses showed evidence of his previous surgery but was otherwise normal. CT of the chest was also normal, and his sweat chloride test effectively ruled out cystic fibrosis. National Jewish performed some further studies. His pulmonary function testing was normal. A metacholine challenge was positive, showing that he did indeed have reactive airway disease. His laryngoscopy showed the vocal cords and the surrounding tissues were diffusely inflamed. On impedance probe, he had multiple episodes of acid and non-acid reflux in the upright position. His exercise challenge test showed the chest tightness that he was complaining of and was noted to be associated with a prolonged episode of reflux. He had no drop in his forced expiratory volume. On upper GI, he had a small hiatal hernia and moderate reflux to the thoracic inlet, but there was rapid clearance. Their impression at the time was that this boy actually suffered from reflux disease. He had a hiatal hernia and associated reflux laryngitis. He had mild intermittent asthma and mild allergic rhinitis. So they adjusted his asthma medications and started him on a proton pump inhibitor. Soon after discharge, he had one further severe episode that lasted 3 weeks, but thereafter he actually did notice a decrease in the severity of his episodes. He still had some barking cough at times, and he still had some exercise-induced chest tightness that he was complaining of. They performed further studies, including bronchoscopy with bronchoalveolar lavage, which was significantly positive for lipid-laden macrophages, suggesting microaspiration. He had endoscopy and biopsies, which were normal, and a follow-up impedance probe, which showed that he had persistent non-acid reflux. Of note, there was a less than 50% correlation with symptoms, which is not unusual. So they recommended continuing him on a proton pump inhibitor and considering a fundoplication. In my opinion, this patient is a very good candidate for surgery. So we all know about the typical, we always think about the typical reflux symptoms with heartburn and possibly regurgitation, but there are, of course, many supra-esophageal symptoms of reflux disease in both children and adults. The American Gastroenterological Association acknowledges an established association between reflux and wheezing or asthma, cough, laryngitis, and dental erosions on the basis of population-based studies. It also proposes an association with reflux and sinusitis, pulmonary fibrosis, pharyngitis, and recurrent otitis media. At this time, there's insufficient evidence to actually prove causation for these symptoms. In babies, we always have to think about apnea and bradycardia as an associated symptom as well. There are many different laryngeal lesions that are related to reflux, including posterior laryngitis, vocal cord nodules and granulomas, subglottic stenosis, and contact ulcers. Now, our body has been pretty good at coming up with protective mechanisms, and when we have small volume reflux and minimal esophageal distension, the upper esophageal sphincter contracts to protect our airway. When we have large volume reflux and thus a lot of esophageal distension, vagal reflexes are turned on, which causes the vocal cords to close, induces central apnea. The upper esophageal sphincter actually relaxes in these situations. The refluxate enters the pharynx, we swallow to clear it, and respiration resumes. And all this happens in 1 second, so we're pretty much unaware of it. Now, 2 mechanisms have been proposed as the pathogenesis of reflux-induced asthma symptoms, the reflux theory and the reflex theory. In the reflux theory, it is purported that direct contact between gastric refluxate and lung tissues is what's causing the problem. So they're saying microaspiration is occurring and we're just unaware of it. The acidic nature of the refluxate, presence of food allergens, and digestive enzymes causes inflammation of the airway and smooth muscles, and this airway inflammation leads to heightened bronchial smooth muscle reactivity. In the reflex theory, we know that the esophagus and the bronchial tree have identical embryological derivations, and so they share common innervation. When these refluxes are stimulated in the distal esophagus by a large volume refluxate, causes a vagal reflex, which produces bronchial constriction. Now, the prevalence of gastroesophageal reflux disease symptoms in adults with asthma is about 25%. The prevalence of gastroesophageal reflux disease as measured by extended pH monitoring in adults with asthma ranges from 50 to 83%, and in children from 50 to 63%. So in a substantial number of patients with reflux-induced or exacerbated asthma, the respiratory symptoms predominate and the reflux is silent, requiring a high index of suspicion and investigations to uncover it. In patients with obvious associated reflux and difficult to treat asthma, the reflux should be treated. But even in patients who don't have obvious symptoms of reflux, this diagnosis must be entertained as a possible exacerbating factor. Indications for workup of asthmatic children without gastroesophageal reflux disease symptoms have been proposed to include radiographic evidence of recurrent pneumonia, nocturnal asthma occurring at least once a week, continuous inhaled high-dose corticosteroids, requirement of 2 or more courses of oral corticosteroids per year, and more vaguely, persistent asthma unable to be weaned from medical management. So there is a role for acid suppression in children with refractory asthma, and this has been looked at by a few different authors. This is a study from 2003 looking at school-aged children with persistent moderate asthma. They had 46 children, all of whom underwent pH monitoring. 58% of them had abnormal pH monitoring, and all of them were treated either with surgery or with medical therapy, consisting of a proton pump inhibitor and a prokinetic agent. All of the patients who were treated medically and surgically in this group, 100% of them had an over 50% reduction in their asthma medications. They had a decrease in their bronchodilator use. They were all weaned off their leukotriene antagonists, and by 6 months after their intervention, 89% of them were completely off of steroids. In the group that had the normal pH studies, a small percentage of these decided to try anti-reflux therapy. 2 of those 8 patients did show a reduction in their asthma medications, but this did not reach statistical significance. Looking at a proton pump inhibitor in reducing symptoms in children with reflux disease, this is a study looking at children aged 1 to 11 who were treated with 2 to 3 months of a proton pump inhibitor. About 80% of the children had either a complete resolution or a significant improvement in their cough. About 65% had improvement in their wheeze, and about 80% improved hoarseness as well. Looking at laryngeal pathology specifically, this is another study looking at 46 children who were treated with a proton pump inhibitor and prokinetic agent. 41% of the patients had severe hoarseness prior to starting the medications, and 55% had severe laryngeal changes on laryngoscopy. After 3 months on treatment, hoarseness was down to 10% of the group only, and the severe laryngeal changes were resolved in most. Only 7% still had them. Now, unfortunately, not all studies show these significant improvements with medical therapy, and it does make sense that surgery might be more helpful as it does more completely combat reflux. We know that even on twice-a-day proton pump inhibitor dosing, breakthrough acid reflux occurs, and of course, non-acid reflux is not impacted. Funkelsrud in 1998 looked at a big group of children. He narrowed down looking at the children who had severe asthma or recurrent pneumonia and reflux, and although only 30% of those patients showed improvement on medical therapy, more than 90% of those who failed to respond to medical therapy had symptomatic improvement of their respiratory symptoms after a fundoplication. Another study a few years earlier looked at 105 children with reflux-induced asthma. Medical therapy was ineffective in 31% of this group. All of these patients underwent surgery for their reflux, and it was noted in the group a decrease in hospital admissions, decrease in ER visits, a decrease in their bronchodilator use, and also a decrease in their steroid use. My partner, Steve Rothenberg, and the folks at National Jewish published this study in 1997. They looked at 57 patients who had reflux and refractory steroid-dependent asthma, and all of these patients underwent a laparoscopic fundoplication. The mean age in the group was 7 years with a weight of 20 kilos. 84% of the patients had significant symptomatic improvement in the first week after surgery. 86% of them were weaned off the steroids, and even in the 8 patients who were not weaned off the steroids, half of them had a greater than 50% decrease in their dose, which is significant in a growing child. 26% had a documented increase in their forced expiratory volume in the first 2 weeks postoperatively. This is actually Steve Rothenberg's experience with 1,800 laparoscopic Nissens. We do a lot of Nissens in our practice. From October of 1992 to April of 2008, he himself performed 1,800 laparoscopic Nissen fundoplications in patients ranging from 5 days to 18 years with a weight range of 1.3 to 120 kilograms. The indications for the fundoplication were the usual seen in a pediatric surgical practice, but of note, 31% of the patients were having their surgery specifically for respiratory issues. Looking at the steroid-dependent asthmatics in the group, there were 229 of these. All of them underwent a laparoscopic Nissen fundoplication with no operative or perioperative complications. And in the past, people were afraid to perform a big surgery on these very sick patients, but the laparoscopic approach has certainly helped with that. 94% of the patients had symptomatic improvement. 95% of them reported a decrease in their inhaler use, and 85% of them were weaned off of steroids completely. 10 patients developed a worsening of their respiratory symptoms from 6 months to 10 years after their Nissen fundoplication. They all underwent an upper GI which showed recurrent reflux, and all of them improved after they had a revision of their Nissen fundoplication. So in conclusion, there is a definite association between reflux and asthma symptoms. Patients resistant to conventional asthma treatment should be considered for gastroesophageal reflux disease workup and treatment. Medical treatment of reflux in these patients is often effective, but surgery may be an even more effective and long-term solution. Thank you.
That was great. Are there any questions from the audience?
Peter Gorecki, New York. I was curious, you didn't give a BMI, but you said it was very obese with striae and Cushinite. One other option, I just want to get your opinion. I didn't get how old was this particular child, but perhaps optimizing anti-reflux therapy and waiting till a child may become more of a candidate for bariatric procedure, which will address also his metabolic problems, but also mechanical problems such as increasing intra-abdominal pressure, which striae implies it, that would address him more globally.
So I don't actually know his BMI, but he wasn't a morbidly obese patient. He just was, obese. He was obese, but not morbidly obese. But it's definitely a good thing to always be thinking about when you're looking at adolescent patients, because of course we don't want to be doing any surgeries unnecessarily. And if we can get them to lose weight, which might end up decreasing their intra-abdominal pressure, and therefore helping their reflux, we definitely should be trying to do those things.
Michael Brunt, St. Louis. I enjoyed your presentation very much, and as an adult surgeon, I sometimes will see patients in the 18, 19, early college student range, and we put them through a lot of testing. I'm just curious, in the adolescent population, what are your criteria for an operation for reflux disease? Do you do physiologic testing in all of those, or if you have evidence of endoscopic esophagitis, you probably don't see a lot of hiatal hernias in that group, but could you just kind of help us in terms of your pre-op testing and how you select them for operation?
Right, so most of the children, pretty much all of the children that we do surgery on do get an upper GI, and one of the main reasons that we do it is because we want to make sure that the anatomy itself is normal, want to make sure we're not dealing with a malrotation that wasn't picked up, which might exacerbate reflux. And apart from that, most of the children do have pH or impedance monitoring to look for real documented reflux. And then part of it also depends on their symptoms and what's happening with their medications as well. If the medications are really helping them, or if it's providing suboptimal management of their reflux. But we actually don't do manometry. Like I know in the adults, you pretty much always do manometry, so we actually rarely will do manometry unless we have a suspicion that the patient has something else like achalasia.
We probably have time for just one more, I'm sorry, Steve.
I guess that's the privilege of being the president. Just to let you know, the
Sorry about that, Joe.
SAGE's executive committee is here in force. You mentioned the use of impedance, and so most of us don't have access to impedance. We're using Bravo or pH probe. Is that critical in this population of the asthmatics that you're using, because the non-acid reflux component of the disease is a critical component to the equation?
Well, I don't think so, and the reason I say that is because a lot of these studies actually were done before impedance was being used, and most of these studies here are looking at patients who are diagnosed with reflux based more on their symptoms as well as the pH monitoring, not the impedance monitoring.
On the other hand, Steve, just an initial comment, more kids have bile reflux than adults, and impedance does help sort that out sometimes.